picture this. You're on the wards, it's a high-stress shift, and you are managing a hospitalized patient with an acute pulmonary embolism.
Right.
But the catch is they absolutely cannot receive anticoagulation. Blood thinners are completely off the table. Maybe it's due to an active, life-threatening gastrointestinal hemorrhage or, a recent major neurosurgical intervention. The tension at the bedside is just palpable.
Oh, absolutely. It's arguably one of the most highly charged scenarios in acute care medicine. You've likely faced this exact dilemma just staring at the chart, trying to figure out the next best move, when the foundational standard of care, systemic anticoagulation, is suddenly stripped away from you.
Yeah, you are immediately forced to weigh the desperate need for mechanical protection, stopping a new thrombus from propagating, traveling to the pulmonary circulation, causing right heart failure against the very real and, frankly, often underappreciated long-term risks of device complications.
Right, the risks of prolonged retention of an inferior vena cava filter.
Oh.
Because the clinical stakes, both immediate and longitudinal, they really couldn't be higher.
So that tension is exactly our mission today. We are going to completely dismantle the uncertainty around IVC filters. We need to clarify exactly when deployment genuinely alters the trajectory of your patient for the better, when it actively introduces harm, and this is key, the absolute critical importance of the removal pathway.
Because when you are standing there evaluating the patient, the psychological drive to intervene is incredibly powerful. It's incredibly hard to fight the reflex to just do something.
Yeah, exactly. When you see that clot burden on the CT scan, the psychological drive to place a mechanical barrier is overwhelming. It feels negligent not to.
That bias of commission is a very well-known entity in medical decision-making. When a patient has an acute PE and cannot be anticoagulated, the immediate instinct dictates that placing an IVC filter is a straightforward, logical, mechanical safeguard.
It offers an illusion of absolute control in a highly volatile hemodynamic situation.
Precisely. We assume that if we block the pipe, we prevent the catastrophic outcome. But if we connect this to the broader physiological reality and look closely at the longitudinal outcomes, that mechanistic instinct completely breaks down. The hard clinical truth is that these filters do not consistently improve overall survival.
Which requires a really decisive paradigm shift in how we practice. We naturally assume that establishing a physical barrier translates directly into saved lives, largely because, that was the prevailing medical dogma for decades.
Right, we viewed the IVC filter as a benign safety net.
But the reality is quite the opposite. These are highly thrombogenic foreign bodies. We are talking about short-term mechanical solutions that frequently create long-term endothelial damage. By altering the laminar flow and leaving a metallic nidus in the cava, the device effectively guarantees the exact morbidity we were originally trying to avoid if it's left in place indefinitely.
The shift is moving away from any concept of routine use. An IVC filter cannot be viewed as a generalized insurance policy. It must be viewed as a highly selective, carefully timed, and inherently temporary intervention.
Temporary being the operative word there.
Absolutely. The new default clinical posture across hospital medicine must be avoidance. We must actively avoid routine placement of inferior vena cava filters in patients with acute pulmonary embolism. The baseline assumption should always be no filter, and you should only deviate from that posture under extremely strict, well-documented clinical criteria.
So if our new default is to avoid these filters, we need to clearly define where we actually draw the line.
Yeah.
To even consider placing an IVC filter, two specific conditions must be met simultaneously. The patient must have an absolute contraindication to anticoagulation, and they must be at a high risk of recurrent PE.
Yes.
We are not talking about a moderate risk or a relative contraindication where we're simply nervous about a little drop in hemoglobin. We are talking about absolute and high.
And we really need to define what high risk of recurrent PE actually means in this context. We are looking at patients who have massive clot burdens, perhaps a large, free-floating, proximal deep vein thrombosis, combined with a cardiopulmonary status that simply cannot tolerate another hit.
Right, a patient with zero reserve.
Exactly. If a patient already has significant right ventricular strain, elevated troponins, borderline hemodynamics, maybe you're seeing McConnell's sign on the echo. Even a small recurrent embolus could be the tipping point into obstructive shock and cardiac arrest. That is the high-risk profile, and clinicians should feel confident in this restrictive approach.
It can feel deeply uncomfortable to withhold a mechanical intervention, though.
It can, but you have to recognize that the downstream harms of unnecessary filters often outweigh their uncertain immediate benefits.
To successfully adopt this restrictive posture, we really have to recognize the common clinical pitfalls that trap even the most seasoned providers. There are established cognitive errors we see repeatedly on the wards.
First and foremost being the assumption of a mortality benefit.
Yes. As we just outlined, the consistent evidence for a survival benefit is simply lacking. We place them under the assumption that we are preventing death, but the physiological data tells us we are primarily preventing recurrent PE in a highly specific, narrow subset of patients.
That is a critical cognitive trap. We are altering the mechanism of recurrence, but we are not definitively extending life across the broader PE population. And that leads directly to the next pitfall, which is using filters as a substitute when anticoagulation is actually feasible.
Which happens all the time.
It happens frequently. A provider assesses a patient and feels the bleeding risk seems high due to advanced age, a history of falls, or minor mucosal bleeding, and they opt for a filter instead.
That is such a vital distinction to make. There is a massive difference between a perceived high risk of bleeding and an absolute contraindication. A patient with a recent non-hemorrhagic stroke who is hypertensive might make us nervous to start a heparin drip, sure, but nervous doesn't equal an absolute contraindication.
Right. And filters do not reduce bleeding. They only theoretically reduce the risk of clot migration. If systemic anticoagulation is physiologically feasible, it remains the definitive gold standard because it actually treats the underlying prothrombotic state.
The filter only treats the mechanical consequence of the clot, leaving the systemic coagulopathy completely unchecked.
Exactly. And another major pitfall we must address is the misapplication of data. We cannot apply this inpatient acute PE data to outpatient or purely preventative settings. The clinical calculus changes entirely outside the walls of the intensive care unit or the medical ward.
We see this sometimes when patients are scheduled for high-risk orthopedic surgeries and there's a push to place a prophylactic filter.
Yes, the physiology, the monitoring capabilities, the acuity of the patient, none of it translates directly to the outpatient or prophylactic arena. The parameters we are discussing today apply strictly to the hospitalized patient with an acute established pulmonary embolism.
So having established those firm boundaries, defaulting to no filter, demanding absolute contraindications, and avoiding prophylactic use, we have to acknowledge that inpatient medicine is rarely black and white.
Almost never.
The guidelines provide a framework, but the patient in front of you often lives in the gray areas. Let's navigate those gray areas, starting with what constitutes a true absolute contraindication, which is the clearest deviation from our no-filter default.
We touched on this briefly, but it is worth expanding. A massive gastrointestinal hemorrhage requiring aggressive transfusion protocols, an active intracranial bleed, or a patient who has just been wheeled out of major neurosurgery or spinal surgery, where even a minor hematoma would cause devastating cord compression.
In those scenarios, therapeutic anticoagulation would be immediately catastrophic.
In those specific, highly volatile scenarios, the mechanical protection of an IVC filter becomes a highly valid and frankly necessary consideration. The alternative is leaving a patient with an established DVT or PE completely unprotected against recurrence, which we know carries an unacceptable risk of mortality.
But the real clinical debate, the one that occupies multidisciplinary rounds for hours, occurs when we encounter severe comorbidities, particularly in the intensive care setting.
The trauma and neurologic intensive care units are the epicenters of this debate.
Absolutely. We're talking about the patient with massive polytrauma. Picture a patient who has been in a high-speed motor vehicle collision with a traumatic brain injury, solid organ lacerations, and complex pelvic fractures. Their risk of venous thromboembolism is astronomically high due to the systemic inflammatory response, endothelial injury, and forced immobility.
But simultaneously, their bleeding risk is equally terrifying.
Right. These populations represent an incredible challenge because they are virtually always excluded from the major randomized controlled trials evaluating PE therapies.
The broad medical evidence does not perfectly apply to the patient experiencing the trauma triad of death, coagulopathy, hypothermia, and acidosis. In these severe comorbidity scenarios, you are balancing competing minute-by-minute lethal risks.
It requires highly individualized, extremely cautious judgment. You cannot simply apply a blanket algorithm. You have to evaluate the dynamic trajectory of that specific patient.
And that trajectory changes daily. A traumatic brain injury, that precludes anticoagulation on day 1 might stabilize by day 5, suddenly making chemical prophylaxis or treatment viable.
But even if you make the calculated decision to place the filter in that polytrauma patient or the patient with the active GI bleed, it brings us to the most critical operational requirement of this entire intervention.
A filter should never be deployed unless there is a reliable, concrete, and thoroughly documented plan for its timely retrieval.
Never. This cannot be overstated. The mechanical benefit of catching a migrating thrombus is inherently temporary, but the physiological risks of a retained filter grow exponentially over time.
We have to look closely at the pathophysiology of what happens when these devices are left in the inferior vena cava. The filter is a metallic foreign body. Within weeks, the endothelial cells of the caval wall begin to grow over the struts of the device.
This neointimal hyperplasia essentially embeds the filter into the vein.
Yes. And while that endothelialization is happening, the filter is actively disrupting the normal hemodynamics. By altering the laminar flow of blood returning to the heart, it creates areas of stasis and turbulence. So over time, the very device meant to prevent a pulmonary embolism becomes a massive, highly thrombogenic nidus.
You are drastically increasing the risk of deep vein thrombosis in the lower extremities.
You also introduce the risk of device migration, where the struts can literally perforate the caval wall, potentially impacting adjacent structures like the duodenum or the aorta. And then there's the ultimate complication, caval thrombosis,
where the entire inferior vena cava can clot off. Managing a patient with a completely occluded IVC is a clinical nightmare, often leading to severe, lifelong post-thrombotic syndrome, chronic lower extremity edema, and intractable venous ulcerations.
It is a textbook example of a short-term mechanical solution creating long-term, irreversible endothelial damage. The device effectively guarantees the exact morbidity we were trying to avoid if we forget to take it out.
The patient only realizes the benefit of the filter when retrieval is assured. The absolute moment the contraindication to anticoagulation resolves the GI bleed is clipped, the neurosurgeon clears the intracranial scan, that filter needs to be scheduled for extraction, and systemic blood thinners need to be initiated.
Which brings us to a sober evaluation of the current medical evidence surrounding this topic, which is notoriously weak, often conflicting, and heavily reliant on retrospective registries rather than robust randomized trials. We have to be intellectually honest about the limitations of our data.
Let's draw a definitive line in the sand regarding the literature. What can we state with absolute clinical confidence, and what do we definitely not know?
Starting with what we can say with confidence based on the aggregate data. IVC filters do not consistently reduce overall mortality in the broader PE population. That is a hard, reproducible finding.
Okay.
We also know that they may reduce the rate of recurrent pulmonary embolism, but this benefit is isolated almost entirely to the specific subset of patients who have an absolute contraindication to anticoagulation.
So we have a lack of mortality benefit across the board and a highly conditional benefit for recurrent PE in a very narrow demographic. What about the claims we cannot support?
We absolutely cannot claim that filters improve survival. Furthermore, we cannot say that they are superior to anticoagulation in general pulmonary embolism populations. When evaluated head-to-head in patients who can safely tolerate blood thinners, systemic anticoagulation is vastly superior.
Because, as we noted, anticoagulation treats the systemic underlying prothrombotic state. It halts the propagation of the clot at the source.
Exactly. A filter simply throws a temporary mechanical roadblock in the path of the embolus without addressing the coagulopathy generating it.
Which brings us back to the provider making the critical call at 2 in the morning. The ultimate safety net, the most evidence-based approach you can take, is to default to no filter unless an absolute life-threatening contraindication is actively preventing the standard of care. Start from a position of no and force the clinical severity of the scenario to convince you otherwise.
And if the clinical severity does dictate placement, your responsibility as the provider does not end when the interventionalist deploys the device. In fact, an entirely new phase of clinical responsibility begins. You must actively monitor for the complications we detailed: migration, lower extremity DVT, and the signs of caval thrombosis.
It requires daily reassessment. You have to evaluate the patient's bleeding risk every single day on rounds to determine if the contraindication has resolved. You are constantly asking, can we start heparin today? Can we start a direct oral anticoagulant today? Because the moment the answer is yes, you must execute the retrieval plan.
If we connect this to the broader picture of hospital medicine and patient safety, the placement of the filter is merely the first step in a mandatory longitudinal clinical pathway. The prevailing cognitive error is thinking of the filter deployment as a definitive final treatment. It is not.
It is merely a temporary bridge to get a highly compromised patient to a state where they can tolerate definitive medical therapy.
A temporary bridge that perfectly encapsulates the physiological reality.
So let's distill this comprehensive review into a definitive, actionable framework that you can take directly to your next clinical shift.
If there is one definitive overarching rule to guide your clinical practice, it is this. In hospitalized patients presenting with acute pulmonary embolism, reserve inferior vena cava filters strictly for those with absolute contraindications to anticoagulation, coupled with a high risk of recurrence. You must ensure a concrete, documented plan for timely retrieval, and you must fiercely avoid routine or prophylactic use due to the stark lack of mortality benefit and the very real severe potential for long-term vascular harm.
It fundamentally changes how we interact with these devices on the wards. But before we conclude this clinical review, I want you to consider a critical operational challenge building directly on this absolute necessity for timely retrieval. Consider your own institution's workflow right now. We know definitively that a forgotten filter is harmful filter. So how can we redesign our operational pathways and electronic health records so that a temporary device doesn't silently become a permanent life-altering risk simply because a patient transitioned out of our immediate acute care?